We're in week 5 out of 6 of content. So let's get started. We're going to talk about the postpartum. Postpartum period is about 6 weeks, may take up to 12 weeks for mom's body to return to its normal non-pregnant state. Not everything is going to return to exactly how it was, but it's going to return to its permanent functioning state. This is known as the 4th trimester. The uterus has to go through changes. It's gone from this very large mass that has held this baby in amniotic fluid, and it has to shrink back down. And that process of shrinking back down is known as involution. Now, it should be clamped down, and it should go from right underneath her breasts, where it was during the last part of her pregnancy, to now after delivery. It's going to be down around her umbilicus. Please don't confuse involution with another term that we used in our high-risk conditions that also starts with an I. Can't remember what that term is? Please go back and look it up so that we don't get these two confused. How are we going to document this? We have to document whether that uterus was firm, so FF, fundus firm, and where it is in relationship to that umbilicus. So U minus 2 means that it's about 2 finger breadths below her umbilicus. So FFU minus 2, that's how we document it. Anybody looking at FFU minus 2 knows that that means fundus is firm, U minus 2 finger breadths. FFU, fundus is firm at the umbilicus. FFU plus 2 means it's 2 finger breadths above the umbilicus. It returns to about a 16-week size, which is about the size of a grapefruit, immediately after delivery. And then it's going to descend 1 to 2 centimeters every 24 hours thereafter. By 6 days, it should be halfway between the symphysis pubis and the umbilicus. By day 9 or 10, we should not be able to feel that in the abdomen any longer. Subinvolution is where that uterus doesn't return to its normal non-pregnant state, most commonly caused because we still have placental pieces in the uterus. It can also not clamp back down like it's supposed to because the uterine lining is infected. Now, is it infected because of the retained placental parts? Could be. Could they have two different things going on? Retained placental parts and another part of that uterus have an infection? Possibly. The risk of subinvolution increases when we have those long, difficult labors, those dysfunctional labors that we talked about, labor dystocia, incomplete expulsion of the membranes and the placenta, a uterine infection, an overdistended uterus, or a full bladder. We're going to talk about where that fundus is in relationship to the umbilicus. And in the postpartum time frame, we want bigger negative numbers. So don't confuse that with station, where a negative number means that baby is higher. In postpartum, a negative number, the bigger the negative number, the smaller that uterus. So at U means that uterus is bigger than U minus 3. U minus 3, it means 3 finger breadths below the umbilicus. After pains, those are contractions after childbirth where that uterus clamps back down. It does some of this on its own, but we also give medications to help stimulate that. When it's contracted down, the muscle fibers of the uterus are like figure of eights around those blood vessels that were feeding the placenta. When it's clamped down, the figure of 8 is clamped down, so it clamps off those vessels so that they can't bleed. If we put baby to breast, it's going to stimulate mom's oxytocin release. This also happens when we do skin to skin, or we give Pitocin via IV. Now, in labor and delivery, we talked about using oxytocin to stimulate the contractions, where we start with very, very small doses and increase by very, very small doses. In our postpartum time frame, if mom is bleeding, we're going to open that up and give her a bolus because we no longer have to worry about overstimulating that uterus to clamp down and causing a fetal problem. The fetus isn't there anymore, so we want that uterus to clamp down and stay clamped down. Cochrane database says that prophylactic use of oxytocics are those drugs that reduce the size of the uterus, cause that uterus to clamp down or contract, reduces postpartum hemorrhage by half, and therapeutic use of it, we've used it prophylactically, we've had some bleeding, so now we're going to give some extra medication, then it reduces that postpartum hemorrhage by 70%. Our after pains, those are those uterine contractions. They're more intense in multipara, and they increase when mom breastfeeds. And that's because in a multipara, it has to clamp down even further because it was overdistended. With breastfeeding, it's releasing that oxytocin that's causing clamping down of that uterus. But that's a good thing. We want that to happen so that we can prevent postpartum hemorrhage. Which patients are more at risk for uterine muscle relaxation? We talked about some of those when we talked about labor and delivery. We just got done talking about one of them. Our multipara, our mom that had multiple fetal pregnancies, a mom that had over distension of the uterus because of hydramnios, our mom who had a very long drawn out labor, our mom who required high doses of Pitocin in labor to cause contractions that helped get her baby delivered. Some of that is it's an overdistended uterus that has to work harder to clamp down, or we have an exhausted uterine muscle that has a hard time clamping back down. The placental site, where that placenta was attached, and if you think about how big that placenta is, that's an entire wound on her uterus now. That placenta, the site has to constrict down because the uterus is constricted down. We have blood clots that are forming there to help prevent some of that bleeding. And then the endometrium also grows over that site to start causing some healing. And it's going to cause some sloughing of the necrotic tissue, allowing normal implantation in the future. But as that heals and as some of that tissue sloughs off while that's healing, that's what's causing some of our lochia. This process is usually complete by about 6 weeks postpartum. That's why moms typically have vaginal discharge for up to about 6 weeks postpartum. We talk about our lochia. And when we describe our lochia, we describe what stage the lochia is, whether it's rubra, serosa, or alba, and we talk about how much. None, scant, moderate, or heavy. You need to know the different lochias and when you would expect to see those because you would want to be able to teach your mom these things. Multipara women, we call them multips, they have heavier bleeding than primips. Bleeding may be lighter after a cesarean section. Now, what's important to note about this, we say that it's normal for our cesarean deliveries to have a blood loss, EBL, of up to 1,000 ml. And our vaginal deliveries, our SVDs, spontaneous vaginal deliveries, it's normal to have up to an EBL of about 500 mLs. However, what we see after our cesarean delivery tends to be less than what we see with our vaginal deliveries. And the reason for this is while they're doing the cesarean delivery, they clean everything out. Then they rinse out the uterus and then they suction all that out. So we've cleaned out all that blood that is collected in that uterus. Whereas with a vaginal delivery, it hasn't been cleaned out. So it looks heavier when we're actually seeing the amount that they're losing externally. The cervix changes. It starts to shorten and firm up in about 18 hours after delivery. The lower uterine segment, the lower part of this, is going to still be very edematous and fragile for several days. If we looked in, which we don't tend to do, but if we were to look at this cervix, it may have this. This may be very bruised. It may have a few little lacerations on it that aren't large enough to suture, but we might be able to see those. The os, the opening of the cervix, is going to close over the next couple weeks. This is a non-pregnant. This is a mom who has never delivered. And then this, we call it a fish mouth appearance. This little slit now is what her cervix looks like now that she has had a child. This is now going to be her new norm. It's never going to go back to this. The vagina and perineum. The vagina returns to its normal size over the next 6 to 8 weeks. However, the rugae may not be as prominent as they were before. The reduced estrogens in lactation decreases vaginal mucus, which is important to tell our moms because that means that they may need some kind of lubrication for intercourse if they're going to be breastfeeding. The introitus, the opening, is very edematous. They may have hemorrhoids. And sometimes with pushing, those hemorrhoids may have gotten a little bit worse. But what we see in the postpartum time frame, most of the time, those shrink and or disappear. Perineum may be very swollen and bruised. So we would want to get ice on her bottom. And we put the ice, we can put it outside of her pad. We would want to wrap it in something. We would never want an ice pack right up against her skin. We're going to look and evaluate her episiotomy or her laceration. Pelvic structure, the pelvic muscular support, might take 6 weeks to regain that tone. We need to be encouraging mom to start her Kegel exercises within a few days after delivery. Hopefully we've talked to her and taught her how to do those prior to delivery. And now after delivery, she needs to do those again to help retain that pelvic muscle tone, and this will hopefully help prevent incontinence or that stress incontinence when they sneeze or cough later in life. Immediately after delivery, those hormones that have caused the sugar and the insulin resistance issues are gone, so their sugars return to lower levels in that immediate postpartum time frame. Delivery of our placenta also decreases all these other hormones of pregnancy. Changes in our endocrine system, estrogens and progesterones drop immediately after the placenta is delivered. That helps with lactation and it helps with diuresis to get rid of all that extracellular fluid. Mom's blood volume doubled. So in the first few days after delivery, mom's going to sweat a lot. All of a sudden, she calls it because her gown and her bed's completely saturated from sweating. And she's up peeing all the time. Well, that urinary frequency is not a sign of a urinary tract infection. It's her body getting rid of all this extra fluid. Ovulation can occur within that first month after delivery in non-lactating women. Periods can return 6 to 12 weeks. We have to remind our moms that they do not have to have a period before they can get pregnant. If they ovulate and they have unprotected sex, they can get pregnant in this first 6 to 12 weeks. And when they come in for their 6-week postpartum checkup and we say, well, guess what? You're pregnant. How can that be? I haven't had a period. You haven't had a period because you ovulated, it got fertilized, and now you're pregnant. So they don't have to have a period in order to be able to get pregnant again. They just have to ovulate. Ovulation in our breastfeeding mom tends to return at a later time frame, maybe up to about 6 months postpartum. This can be used as birth control and can be used for family planning, but it's not 100% foolproof. Our parents need to understand that they need to be very specific and they have to feed very much on a time frame, every 3 hours. Well, baby's sleeping through the night, so we went 6 hours without breastfeeding. That can be long enough that hormones have changed to cause an ovulation. The abdomen. Most of our moms think that they're going to go home in their size 5 skinny jeans, even if they didn't wear size 5 skinny jeans before they got pregnant. A lot of our moms are still going to look pregnant after delivery, and this is very heartbreaking for our moms. Imagine our mom who is very concerned about this, and somebody sees them walking in the hall. They come in to visit and see them in the hall, and it's like, I thought you had your baby. I did. I just still have my baby belly. The abdominal wall is relaxed for about 6 weeks, and diastasis recti that we talked about in early pregnancy can be there. That's the separation of this muscle going up through here. This will take retoning of these muscles to have them go back like this. Our urinary system, kidney function returns to normal within a month. Urinary tract structures return to normal within 2 to 8 weeks. BUN is increased and proteinuria may occur. We talked about the diuresis and diaphoresis, especially at night. Trauma to the urethra or bladder during childbirth can make voiding difficult, and it can make it painful. When we talk about our postpartum teaching, we'll talk about what we can do about that. There may be a decreased urge or inability to void, either due to the trauma or due to residual effects of that epidural that haven't quite worn off yet. What we do need to realize is our full bladder is going to cause our uterus probably to shift locations. And when it's changed or when it's being pushed out from that full bladder, it means that that uterus cannot clamp down. Therefore, mom's at risk for increased bleeding and or hemorrhage. Our moms are hungry. Let's feed them. They've been NPO during their labor, most likely, so they're hungry. Let's get them something to eat. Bowel tone may be reduced, so they may not have a bowel movement for those first couple, 2 or 3 days, and that's perfectly normal. They didn't have any food during labor. They may have had some of that lower bowel evacuation that we talked about prior to onset of labor, and it may just take a little bit. We want to encourage her to get up and ambulate to help stimulate things. The trauma from the childbirth can lead to incontinence, so we want to talk to her about that and let her know that if she's having any of those issues, she needs to make sure she's talking to her provider. Most have an order for a stool softener, so let's offer it. Let's not wait until mom gets so constipated before we offer that. Cardiovascular system, we have a blood loss of up to about 500 mLs after spontaneous vaginal delivery. Average, normal, we say 1,000 for our C-section. It may go as high as 1,500. When we're going to that 1,500, then we have to be concerned that we might be approaching postpartum hemorrhage. Remember how that extra uterine blood flow through that placenta? We've lost that. Think of that placenta as a shunt, and that we've had a massive amount of blood that's been sitting in there for the last 9 months. About 10 to 15% of our blood volume. Loss of those placental hormones stimulate vasodilation and mobilization of our extracellular fluid. Stroke volume increases for about 48 hours after delivery because of all this blood shifting back into the vascular system. Please keep in mind that because of that, we've got all this extra blood going to mom. All this extra blood's carrying extra oxygen. It's telling her chemoreceptors, hey, I'm perfectly happy. I'm getting enough O2. So it can signal the heart to slow down. So our heart rate can be down to like the 50s and still be considered okay. If mom is in the 50s, her blood pressure is still okay, her pulse oxes are still okay. We're not concerned about that lower heart rate right now. The cardiac output can remain increased for up to 12 weeks postpartum. And because of that, and because of all that extracellular fluid that has now been pulled back into the vascular, we might hear a physiologic flow murmur. Our H&H initially transient ischemia because we've pulled that fluid back in, so it looks like a washout. And then it rises postpartum due to the plasma loss that we've talked about, that diuresis, and it returns to normal by about 8 weeks postpartum. Our WBCs and our postpartum time frame can be 2025 and not indicate an infection. We're going to treat mom's symptoms, not her lab values. So if she's running a fever, if she has foul-smelling vaginal discharge, a tender abdomen, an obvious wound in her C-section wound, we're going to treat her regardless of what a lab value is. She remains hypercoagulable, for the first 2 to 3 weeks postpartum. So we need to remind her she needs to be up ambulating. Don't sit with your legs crossed. Don't be stationary. You need to move to keep from getting a blood clot. Our vital signs. Our temperature can elevate due to the dehydrating effects of labor. That means that it can go up to as high as 100.4, and that is not a fever. That's a physiologic change because of all the work and processes her body has done. It means that she might be a little bit dehydrated. We do not need to call our providers because the mom has a temp of 100.3. 100.4, we're normal. 100.5, need to call the provider. Respiration should decrease to within the mom's normal by 6 to 8 weeks postpartum. Pulse returns to non-pregnant levels a few days after postpartum. Blood pressure really isn't altered all that much, but mom's at risk for orthostatic hypotension. When she goes from a laying to a sitting position, that she sits for a minute or two before she stands up, and then she rises slowly. She swings her feet off the bed and goes to stand up. She's liable to have orthostatic hypotension. We want to be with her the first couple of times she's out of bed to ensure that she doesn't get dizzy and that her legs are strong enough to support her. Our neurosystem. This edema during pregnancy could have caused some of our carpal tunnel symptoms, some sciatic pain. Now, maybe with decreasing some of this fluid and some of this edema, those symptoms are going to go away. Need to be very concerned about headaches in our postpartum time frame. We need to assess to rule out preeclampsia. Remember, 30% of our seizures can happen in the postpartum time frame. We also want to evaluate to make sure if she has a spinal or an epidural headache. Remember what those signs of preeclampsia are. They're the same signs and symptoms that we talked about in our antepartum time frame. If you remember leading up to our labor, those hormones like relaxin cause some relaxation of some of our joints. Those joints are completely stabilized by about 6 to 8 weeks postpartum. Some joint changes may be permanent, and the one that's most specifically the most common is mom's shoe size may increase by about a half of a size over her pre-pregnancy weight, and that probably will not change. Common in this postpartum time frame to have fatigue and activity intolerance. Remember what her body has just been through. If you ran a marathon yesterday, you're going to have fatigue and activity intolerance today. Our mom's body has gone through a marathon. And so for now, we're done with the pathophysiology of our postpartum time frame.